We can get started if that's okay with everyone. So my name is Alicia Belden. I'm happy to be able to share these panelists with you today. I'm actually a member of the Capital City Black Nurses Association, and I'm excited about these panelists. We just had our last Pathways in Nursing panel, and it went really well. Got some great questions answered. Hoping we have the same luck here. So this is a panel where we're going to talk to a panel of nurses that have chosen to work in a variety of different roles, both traditional and non-traditional. Just a little bit about me before we get started. I'm a new family nurse practitioner. I have been working at the bedside since 2013, starting in Washington, D.C. as a med-surg nurse, transitioning to the MICU for the past 7 years. Then I did a travel nurse assignment out to Northern California, and I stayed here. Anyways, I recently graduated with a master's level education, and will be starting my new role as a family nurse practitioner at a local community clinic here in Midtown Sacramento. So that's enough about me. Our panelists today, we're going to have Miss Sandra Calderon. She's a nurse practitioner at the UC Davis Cancer Center and Sacramento's National Association of Hispanic Nurses current president. Miss Masara Bembao, I'm sorry if I'm mispronouncing your names. She's an oncology BMT or bone marrow transplant nurse, now working in the outpatient setting. Miss Isada Morton, who has worked over 30 years in a variety of roles, starting as an LVN and now as a hospice nurse. Miss Angelique Silva, she's a perinatal nurse educator and safety specialist at UC Davis. And Miss Irene Cisneros, who recently graduated from the UC Davis Masters of Entry program in nursing, and is now working as a leading cardiac device nurse. So interesting group of nurses here. I'm excited to hear from all of you. It's clear that each of our panelists have unique backgrounds and jobs. So make sure as the audience, you guys listen to their introductions and maybe start thinking of additional questions you'd like to know more about with them. And at the end of the panel, we can put those questions either in the chat box or you can ask, verbally by unmuting yourself. So with that being said, if you ladies wouldn't mind giving yourselves a proper introduction, tell us a little bit about what you do, where you're located, and why you became a nurse in the first place. And maybe we can start with you, Sandra.
Oh, sure. Thank you so much. I really appreciate it. I'm very excited to be with everybody today. As she said, I'm Sandra Calderon. I'm a nurse practitioner currently working at the Cancer Center. I work in the infusion department. A little bit of my background, as kind of mentioned in the beginning, first generation student, came to this country undocumented, got amnesty, worked different positions. I honestly can tell you I never wanted to be a nurse, never thought about it, never considered it, nothing like that. I joined the Army. I did 6 years active duty. When I was in the Army, I was a dental hygienist. I love teeth. I still look at people's teeth all the time. I'm not judging you. I just really like teeth. And that has actually served me very well in my current job. So after I got out of the Army, I went into nursing, which is really weird because my dad asked me to be a nurse and I said, no way, never. And here I am. So I got my BSN from UNR in Reno, Nevada. And I worked a few years at bedside nursing at the VA, got my NP from UC Davis, Betty Everett Moore School of Nursing in 2016. I immediately went to the emergency department, which I can tell you guys, I've never considered working there either. Things happen for a reason. I didn't have experience. If somebody tells you, oh, you can't work here because you don't have that experience, that's not true. I went from a new grad to a fresh NP in the emergency department, which is crazy, but fun, exciting. Again, my dental hygiene skills were perfect in that field because there was so much dental pain that came in. side note on that. So, and then currently, like I said, I'm my position is urgent care nurse practitioner at the Cancer Center, where we serve our cancer patients for any symptomatic complications. Again, the president of NON. So excited to be with you guys. Just, we have so much information to give you. I could just talk all day, but I'm going to stop talking. I'll let the other panelists speak. Again, very excited to be with you guys today.
Excited to have you. Somebody want to jump in? Anybody can go.
Sure, I'll jump in. My name is Ms. Sara Bambao. My maiden name is Castellanos, so I am Mexican. I know that a lot of times it's confusing, but my journey has been a very long journey. I'm currently in the AIM clinic working outpatient, and I work with oncology patients and bone marrow transplant patients. That's my background. Did that for 13 years, loved it until my heart really couldn't take it anymore. And so in the outpatient setting, I feel like I'm still able to connect with those patients, but I'm able to see them walk home or, walk out of the clinic. And that for me is gratifying. So my journey into nursing was a bit bumpy. After high school, I was not focused. I actually was dragged to go to community college by my brother, who kept saying, "What are you doing? Like, let's go to school." And so I finally, accomplished my AA over 10 years. True story. I knew that I wanted to do something. I wanted to help people, but I didn't know in what capacity. And so I took the little survey, and it said that I'd be great for advocating, like a lawyer or even psychology. And I was like, okay. I worked retail pharmacy, and at that time they had a program through Payless Drugstore, who is now Rite Aid, and they would actually send selected participants to be part of a pharmacy technician program. And so I got that free schooling, and it was great, and I loved it because I felt like I could help people, but I felt trapped. I could only do so much, and so I felt really limited. I really believe that everything happens for a reason, and I feel that some of my experiences led me to the right places. And so God blessed me with the son, and it was through my son and through these really, really, really rough times. I ended up on welfare. I ended up unemployed, single mom, and I was really pissed off at myself. Like, how dare did I fall into this stereotype? But I used that to motivate me. I would drive through certain neighborhoods, and I was determined that I was not going to raise my son that way, and that I'm not going to let my hardships define who I am. I was like, okay, my aunt got in my ear. My aunt's a nurse, and she kept saying to me, how you're already doing a lot of nursing care. You're prioritizing care for your son. You can do it. And I was like, God, but I'm not smart enough. I don't have the brains for this. Lies. Don't let that voice get to you. And so I too can talk too much. So I'm just going to stop there and let other people speak. But I'm really excited to share that, don't let your voice or don't let barriers get in your way.
Irene, would you mind introducing yourself too?
So my name is Irene. I want to apologize if you can hear my kids through the walls, and they're playing Nintendo right now. So nursing is the second career for me. I guess you can call it maybe even a third career. I have my master's in exercise physiology from Sac State, thinking I was going to go into physical therapy or cardiac rehab because I really love preventative care. And then 2008, and the economy crashed, and that's when I graduated, and I couldn't find a job. So I kind of use that as, what can I do with the skill sets that I have? Because nobody was hiring an exercise physiologist. And I just luckily got into training with some of the doctors at Sutter and learning cardiac devices like pacemakers and defibrillators and how to test them. Knowing that I had a strong math background, it kind of just worked for me. And then I was recruited from Sutter to come to UC Davis in the cardiology clinic. Working in the clinic, I love seeing my patients on a regular basis. I know them, I know their families, but being a tech, I wanted to do more. I could only do a certain amount of things as a tech. So I went to the Betty Irene Moore School of Nursing and graduated in 2019 from the MEPIN program. Yay, MEPINs. I literally started last year, a week before shutdown, and I started in the ED. So talk about like rushing into everything all at one time. It was pretty much the only position that offered me a job. So I took it, and I'm kind of grateful just because I feel like I got med surg, I got tele, I got ED, I got psych, I got everything all in one. And then when the cardiology clinic said, hey, we have a position, we want you to come lead the cardiac device clinic, I said, okay, I'm ready. I've had some bedside, I'm ready to go back to my patients. So just know that if something doesn't fit, there's always other directions that you can go, especially in nursing.
Thank you for sharing. And we have Angelique in the room now joining us. I'm not sure if you're ready yet, Angelique, but we are answering not really a question, I guess, more doing an introduction of yourself, telling us, you know, a little bit about yourself, where you're located and why you became a nurse.
I could go next unless you wanted Angelique to go.
Oh, either. You can go ahead.
Okay. Greetings, ladies. Thank you for being here. I thank the Betty Irene Moore School of Nursing and CCBNA for doing this. My name is Asata. I have been a nurse over 30 years. I've been a hospice nurse for 17 years at UC Davis. I am currently retired. During retirement, I worked per diem for Yellow Hospice up until COVID. My nursing journey started, well, I wanted to be a physical therapist, wanted to be an athletic trainer so I could feel those guys' bodies and work with the orthopedic handicapped children. Some kind of way, I grew up with my aunt, great aunt, who was a nurse. And I really don't know what she did, but she just looked so regal in her uniform. And back then they had the hats and the white nylons, but yeah, white nylons. And she just looked so magnificent that I wanted to be like her. Again, not knowing what she did. As I went through school, I gave up physical therapy just because it was so impacted and it was difficult. I started with going to Cal State Long Beach. Well, it was an extension program at Dominguez Hills for the physician's assistant program. I had a child who got sick and I had to withdraw during my last 2 weeks of finals for my prereq program. So then I decided I would do fast track nursing, which meant I was going to start LVN. As an LVN, I was able to work as a CNA. Then as I did my LVN, I went to ADA program to get my RN. And while I was working there, doing the RN schooling, I was working as an LVN. Eventually I got my RN. School was so hard that I wanted to do something that was going to keep all the systems in my memory. So that to me was either ER or oncology. Well, I've been a peds nurse, a maternal child health nurse, med surg nurse, and ended up in oncology. Through oncology, everybody was wanting me to become hospice, but then oncology was so new and innovating, and I just thought all my family has cancer. I want to learn how to fix them. So I didn't want to go to a hospice right then because that's a whole different mindset. Well, after 12 years of oncology, then I did 8 years at home health. Then I went to hospice. So I've had a long journey in nursing, but my 17 years at UC Davis Hospice has been the most fulfilling for me. But I couldn't have done any of that without what I did to get there. So I appreciate all of that. And I thank you. And I will stop talking now.
Thank you for sharing. Wow, what a cool journey. Angelique, are you ready for your introduction?
Yes, I didn't have the right code. Sorry, I logged in late. I didn't see the updated Zoom code. My name's Angelique. I'm the perinatal nurse educator at UC Davis. And I honestly have, I've been in school with Sandra. I was Irene's clinical instructor. So I have a lot of connections with some people here on the call. Miss Sarah, I worked on something for her own project for school too. My big thing is I always want to empower young nurses and those wanting to go into nursing, because at a really young age, I was told that because I was a teen mom that I really shouldn't continue on, by my labor and delivery nurse when I delivered my first baby at 16. And that was really at 16, when you're very vulnerable, that kind of tears you apart. But I took it and I ran with it, and it empowered me to do more, and I pushed forward. And so I finished nursing school at the age of 22 and did bedside perinatal nursing for 14 years. Now I'm at UC Davis as the perinatal nurse educator, where I feel like very fortunately we do have a huge voice as nurses in the facility with so many things. And I like to empower the nurses that work on the unit to speak up and to say, I really feel like this can be done better to help safely care for the patients and to create practice changes. It's really important that that the nurses everywhere feel that they can make a difference, and that as potential nurses in the future, that you know that your voice counts. That's a little bit about me.
That's a super powerful message, and I wholeheartedly agree. And we just can't forget that we have those voices, and they are very, they're very special because we have this unique role at the bedside, or not in the bedside, outpatient, where we have like really unique relationships with our patients, and that maybe other practitioners don't have. So people really listen to us all the way up to legislators. So public health in that realm is really important too, for nurses to explore that role too. So we have several questions I was going to ask the panelists, but if you guys think of other questions, feel free to add them in the chat box. But I was going to start asking the panelists these questions, and feel free to jump in, you guys, whenever you want to answer a question. Some of them might not be exactly specific to you, but just answer whatever you feel comfortable answering. So would you guys recommend doing floor nursing before pursuing your specific role?
I can go, since I'm probably the youngest nurse here, as far as years of service. I would highly recommend it. I kind of knew, even going into nursing school, that I wanted to go back to the clinic, but I wanted that bedside skill and critical thinking. Like we say in the ED observation unit at UC Davis, like 1 year of service there is kind of like having 2 to 3 years of service because of how fast paced. And I honestly am glad I started there, because it really does transfer over into the clinic side.
And for me, hospice, you're required to have at least 3 years of med-surg floor nursing. In hospice, we work so independent. You have to be able to have skills that are independent of a team. We do collaborate in a team, but most of our visits are made singularly. Our team consists of the hospice nurse, the social worker, home health aide, the chaplain, the volunteer. And we at some point will do visits jointly, but most of the time the nurse is out there by herself. So it is a requirement for hospice to be a floor nurse first.
I would like to agree with that as well. I think that working at the bedside is really invaluable. You can learn to prioritize, and just because you, let's say, start off in one specialty or not, it doesn't mean that that's your landing spot. I think from my experience, having bedside care really helps kind of put the pieces together in the outpatient setting. And I think that helped pretty much guide me to where I'm at now. So you can start in one area and use that experience and go elsewhere. You don't have to stay in that area wherever you start off at.
Hi guys, I'm going to take this more of a NP kind of nurse practitioner kind of route. Kind of lost track. What I was going to say, sorry. So there's a lot of programs that you don't have to practice nursing to get into the NP program. You kind of are grandfathered in. But I'm going to give you a really quick example of why it's important or highly encouraged. So UC Davis has the program where it's nurse practitioners and PA students together. And I could really see the struggle in the PAs, for example, when we talked about insulin, short acting, long acting, and, you know, BID, QID, finger sticks, all that. They were like deer in the headlight, like, what, glucose of what, and checking this. And I'm like, oh my God, I checked like 8,000 blood sugars in my life, right? Like, yeah, it's so that even that's just one example, right? Of like, as a provider, you're like, okay, I know about the insulins, I know how they work, I know when they're given, I know how to incorporate that in my patient. So that's just one example. I mean, it's you don't have to have it, but I think it's just it's a great thing to have. So take advantage of it.
I agree. As a educator, where I'm part of the leadership team for the unit that I work on. And I do think that it's super important that the leaders on your unit know the work that the nurse at the bedside is doing, so that when different things are implemented in, they're able to relate to the workflows and not just implement because it's coming from higher up, but be actually able to relate it back to the staff and be able to take their input and apply it to the projects. So currently as an educator, I still continue to work at bedside. If the nurses are busy, I jump in and I take care of patients still. I think it's such an important skill to have, to be able to be at the bedside and to be able to relate with your staff in that way as well.
Okay, thank you for answering, you guys. I have another question for you. What is your favorite and least favorite part of your job? And are you fulfilled in the job that you took?
I will.
I guess. Oh, go ahead.
Oh no, go ahead.
We'll start with the bad first. Well, I would say, not having the 312s like you do in the hospitals is pretty rough, and not having a day off. But as far as outpatient, I have a steady schedule. It's Monday through Friday. I can spend the evenings with my kids. I'm not working at night. I have weekends, holidays off. But as far as patient care in the outpatient setting, I know my patients. I see them every 6 months. I talk to their families. I can tell right when they walk in if something's happened, just because I have a very personal relationship with them. And that's hard to do in outpatient an inpatient, unless you're seeing that patient over and over again, like in the ED. But in outpatient, I know my patients really, really well.
One of the things I really love about outpatient, I think I had mentioned a little bit about it earlier, is that I get to see my patients come in and get whatever treatment they need, and then they leave. And it's not so much that them leaving is the best part. It's just knowing that they can continue their life outside of those hospital walls. Being in oncology, I loved being part of their journey and trying to, improve their health and quality of life. But from my perspective, being there for 13 years, I saw a lot of not good outcomes. We see the worst of the worst, right? So for me, it's super gratifying to be able to continue to be a part of their lives, but not be so close to death, so to speak. And that's very gratifying. One of the challenges is that in the outpatient setting, at least where we're at, because it's such a new program, we are, and this is also good, so it's a good and a minus, that we are a part of implementing and starting this program, the outpatient bone marrow transplant program. And so there's a lot of things that haven't been established, and we're kind of establishing policies and protocols as we're going, and we're learning from it, but it can be challenging, but I love it.
Thank you. For me, the challenging is the system that Dr. Perry spoke of at the beginning, the inequality. When I'm doing home care nursing, whether it's hospice or home health, a lot of times things that the patients need is based on insurance or based on their economic status. Sometimes it's a choice between buying medicine or buying food. And there's nobody who to fix that. Some of the doctors will write BID dressing changes. Now, the nurse could go out maybe once, twice a week to do the dressing change, but they may not have hot water. The doctor doesn't recognize they don't have the hot water. Dr. Fred Myers was at that time our medical director. He started having the med students do rounds with us so they would get an idea of the holisticness and the wholeness of a patient. The other part, which is probably everybody's things, is the documentation. Documentation is just too crazy. It's you can't do your work effectively. I can't charge for all of the overtime just because it would be ridiculous, but that was one of my frustrations. My love is the patient and interacting, being able to bring comfort, being able to educate under the circumstances of a loss of a loved one and or even the patient themselves. So I like that, and I really appreciate learning. I learned from all of my patients, whether it was cultural, whether it was just the nuance of that family. That was a real blessing to me. Thank you.
So, piggybacking off what you were saying, I think as a provider, I used to work at the VA, like I mentioned, and the VA is pretty like straightforward. Like, if we don't have, for example, if lidocaine patches, no one's getting lidocaine patches. It's not like this one group of people are getting lidocaine patches. We just don't have it. But, working as a nurse and a nurse practitioner my whole career at the VA, and then going to UC Davis Cancer Center, oh, that was like a shock to my system, because the insurance aspect, the specialists, the people, flying in from different parts of the country to get their care there, not being able to order this specific medication because they have Medi-Cal, and I never really ran into that. So that's the part that's frustrating, because you have a insurance company managing what you can do. That's super frustrating. The great part is everything you guys have mentioned, the patients, the connections, as a, speaking Spanish, connecting with my cancer patients, and a lot of the times they don't understand anything that's going on. I'll spend hours with them going over it. I know Misara, it has the same issue. And, I'm not trying to sound egotistical in any way, but the pay is great. I mean, you have a great career, you work hard, you get the benefits, you get, your insurance, so that aspect, is great. But yeah, the frustration is these insurance companies.
I mean, there are a lot of frustrating parts of being a nurse, or nurse practitioner, or inpatient, outpatient. There's a lot, but there's also some great things. And I think we've heard some of those. But it really is, important for like these new students coming in to know that there is a public health nurse position available, and there are nurses that take a look at the systems in place and try to fix them. So, it helps if you have some bedside nursing experience before you go into that, but that role is necessary and needed. And, I think it's important to hear from seasoned nurses that that's something that we're hoping that somebody can take the reins for, if not us. Did anybody else want to answer that question? I'm not sure if we got through everybody.
I can go. So I'm in a very different role than the other participants on the panel. As the educator, one of the most challenging things that I've had to face is the pandemic and COVID regulations for mother-baby. Being the educator, it kind of all fell in my lap, and there was not a lot out there to help guide me. So I was making it up as I went along. And so the first 3 to 4 months of the pandemic were really, really rough. For myself as the educator, I did a lot of 16-hour shifts, 5 days a week sometimes, because I wanted to make sure that the staff and that the patients were well protected. But all of that work has now paid off, because now the work is so well embedded with our staff that I don't feel that I have to be there all the time now. That now when the pandemic is kicking up again, I think that it's now paid off. So my negative is that I don't have a lot of support in the UC system, because it does all fall on the specific units, where other systems like Kaiser's or Sutter's, they're regional systems, and so you have a team working on all of these protocols. Where at a system like UC, it's individual people working on protocols. But the positive is that I have an amazing team that I work with.
Awesome. Yeah, that sounds really difficult, actually, trying to come up with policies and procedures. Those are bears of a task. I used to work on a committee actually at one of my old hospitals where we would write those together, and it took a long time. So I hear your struggle, and thank you for doing what you did, especially during the pandemic. Let's see, I can ask another question. How about what extra volunteer or committees do you guys belong to? And how or why did you get involved with those committees?
Here I go again. So I started with my son's BSU class, and they have a United Student BSU that's kind of regional. I was the in-house nurse educator. So every time they did a conference, I did a workshop on health. Now, my workshops were probably the least attended, because they would go to sexual relationships or financial planning or leaving the nest. But at one point, they made it mandatory that the freshmen attend my workshop so they could get some information. I'm also a member of Toastmasters. That's a relatively new thing. I'm trying to improve my speaking skills, so don't judge me yet. I'm getting there. I am a member of CCBNA. I'm also a member of Sacramento Black Nurses Association, which has been in existence for about 46 years. And we are doing a lot of collaboration with CCBNA, may even partnership with them in a lot of other ways. I am on the Safe Black Space Community Committee. That's a place where we talk about social inequities. It's a safe place for us to talk, the microaggressions, racism. Next to the UC Davis Healing Circle, which I'm also a part of, that is a multicultural place. Safe Black Space is only for people of African descent. I do a lot, but I guess I could stop and share this platform.
Well, I'd like to share, this may be kind of going into another question, but I'm going to mesh it together. So I'm pretty much kind of a late bloomer in getting involved. My main focus was get to nursing school, finish nursing school, get to working. And then life happened. I fell in love, had the babies, lost some babies. And then I was working on a unit that was difficult. So I wasn't in the right headspace really to get involved. If I were to offer any advice, I would say get involved early, even in nursing school, even while you're doing your prereqs, because networking is so important. And I'm learning that now late in the game, but I'm learning it. And so I've become a member of National Association of Hispanic Nurses. Why? Because I feel that it's important to share that, we all come from adversity, and it's what you do with it and who you surround yourself with. And we can all, lift each other up, and it is possible. Don't, you can accomplish what you set your mind to, and just, put yourself out there. I just also recently became a member of the Diversity, Equity, and Inclusion, DEI Council. Why? Because there's been a lot of crazy things happening, and I'm just tired of it. that's why. And kind of going back to what was spoken about, I think Sandra had mentioned it, I speak Spanish, I'm bilingual, and I love it. I love being able to connect with my patients, sharing the gift that my grandparents instilled, like, you better speak Spanish. And I was like, okay, but no, it's true. It's a gift. And anyway, the struggle is, people that are bilingual or don't speak, patients that don't speak English are kind of not getting what they need. And so I'm tired of that too. So yeah, I guess the moral of the story is get involved as early on as you can. And if you can't, that's okay. Just get involved. I'm also a member of the Oncology Nursing Society and Sigma Theta Tau.
I agree with Masara. I think that's so important to get involved in all of these organizations early on, even like she said, in prereqs, because the more involved you are, even if it's just being a silent participant in the background, just listening in, there's so much education out there that's free, so many resources that are free that you just don't take advantage of because you are so focused in just initiating your career as a nurse. But if you can at all, just throw yourself into all the different organizations and become involved.
So I have to agree. I was actually very involved when I was part of the MEPIN program and in the master's entry program. I was the president during school, a lot of the council. We did a lot of community projects. But I'm going to say that during my first year of nursing with COVID, I did not become as involved. It was too much at one time. But being back in the clinic has allowed me to kind of take a little bit more of a breather. And so I also am a member of NON. And NON provides a lot of opportunities. I'm actually going to help at a vaccination clinic next month at La Superior Market. And I plan in the next couple of years to even become even more involved as far as community. I've done some stuff on my own, even by going to my high school in South Sacramento. That's a Title I high school, and speaking to the students there about nursing. There's a lot of minority students that they don't see somebody of color. So I figured I never got to see that. Why not do that on my own? I don't need, and then I can bring that to the societies that I join as well. So just start wherever you can, even if it's small.
Yeah, I mean, you guys are amazing. Gosh, I don't know if I could follow all that. I have to say, I had no idea there was a Hispanic Nursing Association until like a few years ago. I was really disappointed. I'm like, how did I not ever hear about this, right? And I'm gonna start a PhD program next month, and I have to be 100% honest. Never in a million years did I ever think about going back to school, and never did I ever think about being a PhD. My friend is a PhD. I remember visiting her in Wisconsin, and she showed me all the stuff she had to do. And I was like, I just want to vomit right now. Like, ugh, that looks awful. And here I am years later pursuing that. But what motivated me is 100% NON. I went to a leadership conference in Washington, D.C. After that conference, honestly, I could tell you I was completely changed. Seeing so many people that look like me that were deans and like running companies. And I was like, wow, there's so many successful Hispanic people. Where have they been, right? So my goal in getting my PhD is just to help more Hispanics get into nursing, period. Very easy. It's not easy, but I mean, it's a very simple goal. That's my goal. I'm not going to say it's simple. Sorry. My passion is very simple, but it's going to be difficult. And I know that with the help of everyone here, like there's so many new connections. I've been writing down people's names. I'm like, ooh, that person, connect with them. So yeah, great opportunity for networking.
Oh, wow. Actually, that kind of brings up a different topic. And I was just wondering if you guys wanted to share I know that, you know, a lot of people here are new to nursing or haven't started their nursing careers yet, but do you have any personal stories about maybe seeing somebody that was a person of color or something that needed care and you helped them in some way, maybe where they weren't being helped before by other staff? For instance, if somebody needed, you know, translating help, not only just because they didn't understand what the procedure was, but maybe like it helped them connect to their health better, and, you know, overall, like their quality of care was much higher because you were there, instead of somebody else in your place.
I think we probably all have. I want to say myself, my master's thesis was on equity in the Hispanic community with diabetes, specifically with gestational diabetes. And it was more related to the education that was being provided to them was not culturally sensitive. So they were being told to eat like celery and peanut butter, food that they never would eat in their lives, where it really needs to be brought back to what do they normally eat culturally? What can you take from their foods that they eat every day and tell them, okay, maybe eat a portion of rice, a portion of beans, smaller portions, but then you can increase the amount of like ceviche that you eat, because ceviche is great, right? Everybody loves that. So being able to speak their language and the food that they actually love, that makes such a huge difference with them actually being successful with their plan of care. And I think that that is really important. And I would bet that almost everybody on the panel has probably had experiences like that.
Absolutely. For me, you know, I think there's a lot more to utilizing an interpreter. I think it's very important, and I think that we're not utilizing interpreters as we should. But I also know that there is no replacing that connection that you know, a Mexican American person can connect with someone culturally, right? I had a patient who, you know, they were using the interpreter appropriately. She was understanding her care, and some of the you know, people were talking that, oh, she doesn't have anybody visiting her, she's a single mom. And when I was talking to her, I realized that she was experiencing a lot of pain. She was married, and she was having marital problems, and she was beating herself up pretty much. And that's just information that would not have been picked up had we not been able to have that conversation and connection. That's not, the interpreters I feel like are often used for like a transaction. "Oh, we're going to do this. Do you understand this? This is your med," you know. But when you are able to use your bilingual language to connect with that patient, it goes a long way. Yeah.
Thank you. For me in hospice, it was based on I was the only African-American hospice nurse. And when I would go to patients, we work weekends, we would rotate weekends. A lot of times I would see other patients, other staff patients who were African-American. And my whole approach, and they were like, "Can I have you as my nurse? They don't do this, they don't do that." One of the things is respect how you enter someone's home. I appreciate hospice because I have to ask your permission. Just because I'm a nurse, I'm not going to barge in and just tell you do this, do that. And that's what a lot of my coworkers, minus Miss Teresa, a lot of my coworkers were doing. I had to explain to them. I tried to explain to them. You address people, especially seniors, by their Mrs. Jones, Mrs. You don't say, "Hi, Sally. Now I'm here to," I had to explain that to them. And again, in terms of the diet, you know, hospice nursing, we covered everything, your diet, your sleep, all of that. And then bringing that information back to my team to gently say, when you come into an African-American person's house, even though there may be 3, 4, whoever, many people, you speak to the people. You don't ignore them because you think they're going to, I don't know, attack you. One of my coworkers said, "Oh yeah, if you go in the morning, they'll be sleeping, so nobody will bother you. You can feel safe there." So that was a whole nother education that I had to bring with my team. And my team, because they're hospice nurses and they're independent, they think they have the latest and greatest. Oh, I know that. Asian people only like hot water, and Mexican people, you got to speak to the male, or just those stereotypical. But having to sit down with my team and actually have a real conversation about people of color was very difficult. But when you do that, you're able to provide the care and add the trust that these people are going to give you while you are walking them through losing one of their loved ones. So it was challenging, mostly with my staff that I was working with, trying to treat people of color and using the interpreters properly. If I went to a Hmong house, I'm going to speak to the Hmong interpreter about culture. What should I do? What should I not say? And please let me know and let the family know to guide me if I'm saying that's something that's not right, or I'm getting ready to do a procedure or say something that's not culturally appropriate. I'm here to learn. That was my frustration, but also my joy, because when I got through, it was such a rewarding time to be able to assist my clients.
I think that's really important. One of the points that I just wanted to highlight there is it's so important to ask somebody. Just ask them, what's disrespectful to you? What are you expecting of me? And I think that you start learning that as a nurse once you get to the bedside, but it's good to know up front for sure, because I've definitely had nursing coworkers and friends that have had very bad experiences with patients because the patient took whatever they did, maybe as an accident, very badly. And when you start off your journey with them, when you start off your shift with that patient and it's negative, they're not going to listen to what you have to say. And a huge part of being a nurse is educating the patient and motivating them to take care of their health. So yeah, I think it's really important that it all starts with respect of that patient and just coming at it from that angle. Does anybody else have an experience they want to share?
I have an experience. I have a little bit different background as a non-Spanish speaking Latina nurse. My mom's side of the family, I'm like third or fourth generation, as I'm first generation on my dad's. So when my grandparents were raising my mom in the 70s, here, especially in Sacramento, it was very frowned upon to speak Spanish. So he did not teach my mom Spanish, which in turn led me to not learn Spanish. So when I do have Latinx patients and they see my last name, they think that I speak Spanish. It's really difficult for me because I don't speak Spanish very well. I try my best, but it's not the best Spanish, and medical Spanish is completely different. But I will say, just as a person of color, having other patients that are patients of color is profound. One of the patients that I specifically remember in the ED observation, she was Arabic. She did not speak English, and she was actually able to have her daughter with her because of that, even though we had no guest policy during the pandemic in the ED. And I think just showing her respect and asking about their culture and what was appropriate when the daughter had to leave for the night, just having her say, I'm so glad it was you. Thank you for being respectful. And I actually feel okay leaving my mom in your care because I know you'll take care of her. I think that alone made me feel a lot better, because there is, a stigma when you are a person of color, especially as a nurse. You see somebody else that may have had some similar struggles or just respectful of your culture. It gives the patient a little bit more ease that you're going to take good care of their family member.
I'll go quickly. I had a very sad 26-year-old male, newly diagnosed with stage 4 hepatic cancer. It was an all-day event. He just looked terrible. He was in a very bad condition. The family didn't understand the severity of his cancer. They didn't understand that he was stage 4, he was terminal. They're talking about, which I believe in miracles 100%, but they were talking about curing him and, like just just, and it just wasn't, they just didn't connect the dots. And it took me a very long time, a lot of sitting with them, answering all their questions. And that's the problem, is our system doesn't allow patients to ask a lot of questions. You know, like most patients get 15 minutes, right? In the cancer center, they get 30. But when you add in an interpreter, it's like 5 minutes. So I've had multiple patients that I've had to sit with, and it's taken a lot of time, but I love it. And it helps with their care. And I'm always, when I see them, it's an instant connection, right? Language is a connector. So when I see them, I ask them, how are you doing? And of course they tell me like 20,000 things, right? But I'm always like sending the providers, hey, this patient is complaining of this. Can you speak to them? Can you follow up? So it's a service. It's my, I feel like it's my duty. And as a Spanish speaking provider and as just a human being, to just help them in any way I can. And it's, of course, they don't have to speak Spanish for me to do that. But, you know, like I said, it's a connector that we have.
All right, well, it looks like we have a little bit less than 10 minutes left. So if you guys have any more questions for the panelists, feel free to, you know, unmute yourself and ask. I think somebody had a question about midwifery. I'm not sure if you still want to ask that. And then we'll go from there. One of the questions in the chat box is, what are you guys doing for self-care?
I love Teresa and her self-care questions, because she's always worried about making sure that we take care of ourselves, which is honestly so important, because if not, we will wear ourselves out and we will leave the profession. So many nurses are leaving the profession. And I think everybody's self-care looks a little bit different. What I have done for myself in the last maybe 6 months since we've been able to, is I try to do as many massages as I can, because I need to be able to just disconnect from everything and enjoy a lot of music therapy, a lot of just a meditation. Those are like, that's the self-care that speaks to me, because it's time by myself. I need time by myself, away from all of the stimuluses out there.
Where do you get your massages?
I have somebody I've been seeing for years. So when she reopened up, I started to go back again, once a month at least.
Anybody else?
Yeah, I'm gonna be corny because that's just who I am. But I love exercise. I love for me I'm in a place where it's not about it's about the feeling, like what it makes me feel like. I literally need my exercise for my mental health. So I bought a little bike. I used to try to go to the gym, but with the pandemic, it just was not safe. And at one point they shut down. So I try to do that. I have a dog. I love him and he loves me, and I take him for walks. I like to spend time with my kids and my husband. Just try to, you know, do things that make me happy. And you know what? There's some days where my self-care, just like Angelique said, will look different. Like I don't want to do anything. I just want to be a couch potato. It's very hard for me to do that because I feel like I always feel guilty. I feel like I need to do something, but I'm learning the art of nothing. So
That is very hard to learn, especially as a nurse. Anybody else have anything that they do to relax after a hard shift?
Yeah, I have the same lines as also exercise. But one thing that, especially for new nurses, that I had to learn, especially working last year in the ED as a new nurse, is I've actually reached out to ASAP. I cannot remember what it stands for, but it's, you know, the counselors for UC Davis, to speak to them via Zoom. There was a lot of, you know, trauma that happened, seeing what we saw in the ED, not knowing, you know, policies literally changed in the ED within an hour. And although I wasn't on the trauma side where people were being intubated, we did get admitted COVID patients. And, you know, I was just trying to learn the job. And now I'm trying to learn the job in a fast-paced situation during a pandemic. It didn't really hit me until this year. And that's when I realized I needed to speak out and talk to somebody about the stuff that I had seen. So being able to, and, you know, as the Latinx, we never talk about mental health, but going through the MEPN program, we preached it, we talked about it, and I'm so thankful because I said, you know what, I need the mental health help. I'm going to use the resources that I have to talk to somebody to get over some of those hurdles. So I think that's part of my self-care.
Thank you, Irene, for bringing that up. I 100% wholeheartedly agree with you. If you feel like you need to reach out to talk to somebody, definitely. I've had to do that myself with no shame. I reached out to ASAP, cried my eyes out, because sometimes I just need to talk to somebody that's not involved in whatever's happening. And so an objective person, right? And so I think that's really important, and get rid of the stigma. We're all human and we all have some sort of pain at some point.
Yeah, for me, that's what my safe Black space is. It's a place where I could kind of get together with other people. Although I am a facilitator, we still get to share and we get to assist other people. We're not a mental health group, but we offer resources. We provide resource lists. My self-care, I travel a lot. It's a little more difficult, so I'm wondering how much self-care I'm doing just to travel because of COVID. Like after this Zoom, I got to run down and get my my COVID test to make sure so I could travel. I'm leaving on Monday, but I travel, I read, and I just try to become more of a energetic, vibrative, spiritual person, and that means different things to different people. So it's going to be, but I'm just reacclimating myself with that journey. And it's just so amazing. And to be able to still recognize that there's that human self-care. And that's where my volunteerism comes in at as well, because now I basically could do it when I want to do it and not have to do it as a job. So that makes a big difference. And that's how I take care of myself. And then I get on Zoom like this, and people like Teresa, everybody, she's a doll to all of us. I see everybody's giving her accolades, and I just appreciate her. And I know if I ever needed something, self-care or directions on self-care, since that's one of her things, she could definitely point me in the right direction.
I have to say, for me, it's definitely Jesus. I pray constantly every day, multiple times a day. I started reading more devotionals. That's my number one. I'm a reality show junkie, so I love to just sit and watch housewives or cooking shows, or yes, it's like it doesn't use your brain in any way, right? So I also started doing like a half marathon trainer on my phone. I love going down to the American River, going on the trail, doing the runs. And I used to run like for like competitiveness in my own self, but now I do it because it's enjoyable. And it sounds weird to run to enjoy, but I think I've taken the stress off of the running and made it more of just like a time for myself, self-care, right? So yeah.
Yeah, I mean, all those resources, all those ideas that you guys threw out, those are great ways to stay, relaxed and not have so much stress as can be placed on us during this job. It's taxing sometimes, especially right now. Well, it looks like we're pretty much at the end here of our panel. So I appreciate you guys. Thank you so much to all the panelists that participated. Really appreciate hearing about your roles. And I think we'll be joining the main session now. So unless you have any further questions, we'll just ask for these panelists to share their information to the group, either in the chat box or in the main meeting comment area. So in the main meeting chat box, I'm not sure what that's exactly called, but I appreciate it, and we'll see you guys soon.